Why is it essential to distinguish iron deficiency anemia (IDA) from anemia of chronic disease (ACT), and how can this be done diagnostically? Answer: distinguishing iron deficiency anemia (IDA) from anemia of chronic disease (ACT) is crucial because these conditions have different underlying causes and treatment approaches. IDA typically arises from inadequate iron intake, chronic blood loss, or malabsorption, leading to decreased hemoglobin synthesis. ACD, however, is typically secondary to chronic inflammation, infection, or malignancy where iron is sequestered in macrophages and not available for erythropoiesis despite normal or elevated total body iron stores. Diagnostic strategies for differentiating these two conditions include serum ferritin. Ferritin is a marker of iron stores in the body. In IDA, ferritin is low, reflecting iron depletion, whereas in ACD, ferritin is often normal or elevated due to its role as an acute phase reactant indicating inflammation. Total iron binding capacity (TIC). In IDA, TIBC is typically elevated as the body tries to compensate for low iron by increasing transferrin, the iron transport protein. In ACD, TIBC is normal or low. Transferrin saturation (SAT). In IDA, TSAT is low because of the reduced iron available for binding. In ACD, TSAT may be normal or slightly reduced, but rarely to the extent seen in IDA. Reticulocyte hemoglobin content (EHR). In IDA, EHR is decreased, indicating insufficient iron for erythropoiesis. Correctly diagnosing and differentiating these two conditions is crucial as IDA is treated with iron supplementation while ACD management focuses on addressing the underlying inflammatory or chronic condition. Describe the key differences between ischemic and hemorrhagic strokes in terms of pathophysiology and management. Answer: ischemic and hemorrhagic strokes represent two distinct pathophysiological processes with different management strategies. Ischemic stroke pathophysiology. Ischemic stroke occurs when a blockage, thrombus, or embolus obstructs a cerebral artery, depriving brain tissue of oxygen. This blockage can be caused by atherosclerotic plaques, blood clots from the heart, e.g., in atrial fibrillation, or other embolic sources. Management. The first step in ischemic stroke management is to restore blood flow. Thrombolysis with tissue plasminogen activator (TPA) is indicated within the first 4.5 hours from symptom onset to dissolve the clot. Mechanical thrombectomy is another option for large vessel occlusion, particularly within 6 to 4 hours. Secondary prevention involves antiplatelet therapy, e.g., aspirin or clopidogrel, and anticoagulation in cases with atrial fibrillation. Blood pressure management and lipid-lowering medications, e.g., statins, are also important for long-term prevention. Hemorrhagic stroke pathophysiology. Hemorrhagic strokes are caused by the rupture of a blood vessel resulting in bleeding into the brain. This can be due to conditions such as uncontrolled hypertension, aneurysms, or arteriovenous malformations. The bleeding leads to an increase in intracranial pressure and damage to surrounding brain tissue. Management. Immediate management focuses on controlling blood pressure to prevent further bleeding. Medications like labetalol or nicardipine are used for this purpose. If the patient is on anticoagulants, reversal agents like vitamin K or prothrombin complex concentrate are administered. Surgical intervention may be required to evacuate the hematoma or treat any underlying vascular malformations. If there is no active bleeding, a conservative approach may be used with careful monitoring. Early differentiation through non-contrast CT or MRI imaging is crucial as it prevents inappropriate treatments such as EPA administration in hemorrhagic stroke. Emily, a 35-year-old woman, presents with spontaneous bruising, petechiae, and heavy menstrual bleeding. Her platelet count is 18,000 more. She denies medication use and no systemic illnesses are noted. Peripheral smear shows no platelet clumping. Coagulation studies are normal. What is the most likely diagnosis and what is the initial management? Answer: the most likely diagnosis is immune thrombocytopenic purpura, the condition where the immune system produces antibodies that target platelets for destruction, leading to thrombocytopenia. A TP typically presents with isolated low platelet counts and no other systemic abnormalities as seen in Emily's case. The normal coagulation studies and absence of platelet clumping on the peripheral smear further support this diagnosis. Initial management involves corticosteroids, e.g., prednisone, to suppress the immune response and reduce platelet destruction. Steroids are the first-line treatment, with doses typically ranging from 1 a.d. Intravenous immunoglobulin (IVIG), administered in cases of severe thrombocytopenia or active bleeding to quickly raise platelet counts. IVIG works by saturating Fc receptors on macrophages, preventing platelet destruction. Platelet transfusion, reserved for cases with life-threatening bleeding or extremely low platelet counts 10,000 more. If the patient does not respond to initial therapies, second-line treatments such as rituximab, thrombopoietin receptor agonists, or splenectomy may be considered. Regular follow-up is essential to monitor platelet levels and adjust therapy. Discuss the pharmacologic management of generalized tonic-clonic seizures and explain the rationale behind the drug selection. Answer: generalized tonic-clonic seizure (GTCS) are a type of seizure that involves both hemispheres of the brain and typically results in loss of consciousness, muscle rigidity, and convulsions. The goal of pharmacologic management is to control the seizures, minimize adverse effects, and improve quality of life. Valproic acid, first-line treatment. Mechanism: valproic acid increases gamma-aminobutyric acid GABA levels and inhibits excitatory neurotransmission through sodium and calcium channel modulation. It is effective against multiple seizure types, including GTCS, and is particularly useful in patients with generalized epilepsy. Considerations: it is highly effective, but its use is limited in pregnant women due to teratogenic effects. Levetiracetam. Mechanism: levetiracetam binds to synaptic vesicle protein 2 (SVA), modulating neurotransmitter release and reducing neuronal excitability. Considerations: it has a relatively benign side effect profile with minimal drug interactions, making it an excellent choice in polypharmacy situations. It's effective for GTCS and is often preferred for elderly patients due to its safety profile. Lamotrigine. Mechanism: lamotrigine works by inhibiting voltage-gated sodium channels, which prevents the spread of epileptic discharges across the brain. Considerations: lamotrigine has a slower onset of action but is highly effective, especially in patients with concurrent mood disorders. It is well tolerated, but there is a risk of Stevens-Johnson syndrome, a severe skin reaction when starting treatment, requiring slow titration. Rationale: the choice of antiepileptic drug depends on the patient's comorbidities, age, and tolerance to potential side effects. Initial therapy often starts with one agent, and additional drugs are added if seizures are not adequately controlled. Or DS require regular blood level monitoring for efficacy and toxicity, particularly in the case of valproic acid, which has a narrow therapeutic window. Explain the diagnostic criteria and staging for multiple myeloma, incorporating the relevant laboratory and imaging findings. Answer: multiple myeloma (MM) is a hematologic malignancy characterized by the clonal proliferation of plasma cells in the bone marrow, which leads to monoclonal protein production and related complications. Diagnostic criteria: CRAG criteria. Clonal plasma cells 10% in the bone marrow, or evidence of a plasmacytoma, a tumor of plasma cells on biopsy. Presence of at least one of the CRAB criteria. Calcium elevation, serum calcium 11 mdl, renal dysfunction, serum creatinine UDL, anemia, hemoglobin 10 gram below. Bone lesions typically seen on X-rays, MRI, or PET scans as lytic lesions, which are areas of bone destruction. Staging: the revised International Staging System (RS) stages multiple myeloma based on serum B microglobulin and lactate dehydrogenase LDH levels. Stage I: low B microglobulin 5.5 EGL or elevated LDH. Imaging: skeletal survey. X-rays may show lytic bone lesions, which are indicative of the disease. MRI or PET scans may also be used to assess bone marrow involvement and detect plasmacytomas that may not be visible on X-rays. The disease is confirmed through serum protein electrophoresis (SPEP) or urine protein electrophoresis or PEP to identify monoclonal proteins, M protein, which is characteristic of multiple myeloma. What are the clinical manifestations and treatment strategies for chronic inflammatory demyelinating polyneuropathy (CIDP? Answer: chronic inflammatory demyelinating polyneuropathy (CIDP) is a rare immune-mediated disorder characterized by progressive or relapsing weakness and sensory loss due to demyelination of peripheral nerves. Clinical manifestations: progressive or relapsing motor and sensory symptoms. CIDP typically presents with proximal and distal weakness, especially in the lower limbs, and may affect the upper limbs as well. Sensory disturbances: patients may experience paresthesia, numbness, or tingling. Hyporeflexia or areflexia, reduced or absent deep tendon reflexes are common due to impaired nerve conduction. Fatigue and pain can also be present. Diagnosis: diagnosis is made based on clinical presentation and findings on electrophysiologic testing showing demyelination, slowed nerve conduction velocities. Cerebrospinal fluid (CSF) analysis may show albuminocytologic dissociation, where there is an elevated protein concentration in the CSF without a corresponding increase in white blood cell count. Treatment: First-line treatment: corticosteroids, e.g. prednisone, help suppress the immune response and reduce inflammation. IVIG, intravenous immunoglobulin, is also effective in many patients and helps modulate the immune system. Second-line treatment: plasmapheresis can be used for patients who do not respond to steroids or IVIG. This procedure removes harmful antibodies from the blood. Immunosuppressive agents, e.g. azathioprine, cyclophosphamide, may be considered in refractory cases. The treatment plan is typically individualized and patients are monitored for both the progression of the disease and the side effects of the therapies. Discuss the pathophysiology, diagnosis, and treatment of Parkinson's disease. Answer: Parkinson's disease (PD) is a progressive neurodegenerative disorder characterized by the degeneration of dopaminergic neurons in the substantia nigra, leading to a reduction in dopamine levels in the basal ganglia, resulting in impaired motor function. Pathophysiology: dopamine deficiency impairs the function of the basal ganglia, leading to bradykinesia, rigidity, tremors, and postural instability. The hallmark features of PD: the exact cause of the dopaminergic neuronal degeneration is unclear, but genetic and environmental factors are believed to play a role. Diagnosis: clinical diagnosis is based on the presence of motor symptoms, e.g. bradykinesia, resting tremor, rigidity, and postural instability. A positive response to dopaminergic therapy, e.g. levodopa, supports the diagnosis. Neuroimaging, e.g. MRI or DAT-SPECT scans, may be used to rule out other causes, but these are typically not required for diagnosis. Treatment: levodopa-carbidopa increases dopamine levels in the brain and is the most effective treatment for motor symptoms. Dopamine agonists, e.g. pramipexole, ropinirole, stimulate dopamine receptors. MAO-B inhibitors, e.g. selegiline, prevent the breakdown of dopamine. The COMT inhibitors, e.g. entacapone, prolong the effects of levodopa. Deep brain stimulation: for refractory cases, DBS is used to modulate abnormal brain circuits. How does disseminated intravascular coagulation, DIC, present clinically, and what other management strategies? Answer: disseminated intravascular coagulation, DIC, is a complex and life-threatening condition characterized by widespread activation of the coagulation cascade, leading to both thrombosis and hemorrhage. Clinical manifestations: acute DIC often presents with bleeding, e.g. from the gums IV sites or surgical wounds, and microvascular thrombosis leading to organ dysfunction, e.g. renal failure, respiratory distress. Chronic DIC may present with a history of recurrent thrombotic or bleeding episodes, often associated with underlying conditions like cancer or infections. Diagnosis: elevated D-dimer levels indicate widespread fibrin degradation products. Prolonged PT prothrombin time, activated partial thromboplastin time, and low fibrinogen levels are typically seen. Thrombocytopenia is common due to platelet consumption in microthrombi. Management: treat the underlying cause, e.g. infection, trauma, malignancy. Supportive care with blood products. Platelet transfusion for thrombocytopenia. Fresh frozen plasma for coagulation factor deficiencies. Cryoprecipitate for fibrinogen replacement. Heparin may be used in some cases to prevent thrombus formation, particularly when thrombosis is the primary issue. However, its use is controversial in acute DIC with active bleeding. The condition requires a multidisciplinary approach for management and close monitoring. What are the diagnostic criteria for epilepsy, and how is the management of seizure disorders determined? Answer: epilepsy is a chronic neurological condition characterized by recurrent, unprovoked seizures. Diagnosis and management depend on the type of seizures, the underlying etiology, and the patient's response to treatment. Diagnostic criteria for epilepsy: 2 or more unprovoked seizures occurring more than 24 hours apart. 1 unprovoked seizure with a high likelihood of recurrence based on clinical or EEG findings. Management: initial treatment. The first-line treatment for most generalized seizures is valproic acid, while lamotrigine or levetiracetam may be used for focal seizures. Seizure classification: the treatment plan may differ based on seizure type, e.g. tonic-clonic absence, myoclonic. Secondary causes: if seizures are due to an underlying condition, e.g. brain tumor, stroke, treatment focuses on addressing the root cause. Resistant seizures: for patients with refractory epilepsy, alternative therapies such as surgical resection, vagus nerve stimulation, or a ketogenic diet may be considered. Explain the management of acute ischemic stroke in the emergency department, including thrombolytic therapy considerations. Answer: the management of acute ischemic stroke in the emergency department is time-sensitive and requires rapid assessment and intervention to restore cerebral blood flow and minimize brain injury. Initial assessment: history and physical exam. Time of onset of symptoms is crucial for determining eligibility for thrombolytic therapy. Non-contrast CT scan to rule out hemorrhagic stroke. Thrombolytic therapy (EPA) tissue plasminogen activator is the only FDA-approved thrombolytic agent for ischemic stroke and should be administered within 4.5 hours from symptom onset. Eligibility criteria: no evidence of hemorrhage, no recent surgery or trauma, and no contraindications such as recent anticoagulant use or a history of intracranial hemorrhage. Dose: TPA is administered as a bolus followed by an infusion over 1 hour. Other management: antiplatelet therapy (G) aspirin is initiated after thrombolysis to prevent recurrent ischemic events. Antihypertensive therapy may be required if blood pressure exceeds 185/110 Hg before thrombolysis. The key to success is rapid intervention, and a multidisciplinary team including neurologists, stroke specialists, and emergency physicians is essential. A 65-year-old patient presents with exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Echocardiography reveals an ejection fraction F of 35%. BNP levels are elevated. What is the likely diagnosis and what are the key steps in management? Answer: the patient is likely suffering from systolic heart failure, HREF due to the reduced EF. Management involves lifestyle modifications, sodium restriction, weight monitoring, pharmacological therapy, ACE inhibitors or ARBs if ACE inhibitors are contraindicated, reduce afterload and improve survival. Beta blockers e.g. carvedilol, metoprolol succinate, improve cardiac remodeling and reduce mortality. Mineralocorticoid receptor antagonists e.g. spironolactone, especially if F35% diuretics. For symptom relief e.g. furosemide, if indicate DLT inhibitors e.g. dapagliflozin. For additional mortality benefit, device therapy, ICD or CRT in selected patients, F30% LBBB, etc. Management of comorbidities, ensure adequate control of hypertension, diabetes, and arrhythmias. Which pharmacological treatments are most effective for reducing exacerbations in patients with severe COPD, and what is their mechanism of action? Answer: for severe COPD, long-acting bronchodilators, LAMA. G. Tiotropium reduces bronchoconstriction by inhibiting muscarinic receptors. LABA. G. Salmeterol relaxes airway smooth muscle by stimulating beta-2 receptors. Inhaled corticosteroids used in combination with LABA to reduce inflammation. G. Fluticasone salmeterol. ED4 inhibitors e.g. roflumilast for patients with chronic bronchitis and a history of exacerbations reduces airway inflammation. Guidelines: GOLD 2024 emphasizes dual therapy, LAMA plus LABA for moderate to severe COPD and triple therapy, LAMA plus LABA plus for those with frequent exacerbations. Mr. James, a 50-year-old man, presents with chest pain that is sharp and worse with inspiration. The pain improves when sitting forward. ECG shows diffuse and segment elevations. Echocardiography shows a small pericardial effusion. What is the most likely diagnosis and what is the appropriate management? Answer: the most likely diagnosis is acute pericarditis. Key points: diagnostic features: pleuritic chest pain, pericardial friction rub, diffuse ST elevation on ECG, and pericardial effusion on imaging. Management: NSAIDs e.g. ibuprofen. First line for inflammation: colchicine reduces recurrence rates. Corticosteroids only if NSAIDs and colchicine are contraindicated or ineffective. Hospitalization if there is hemodynamic instability or suspected tamponade. Guidelines: ESC guidelines recommend colchicine for all patients with acute pericarditis unless contraindicated. A 45-year-old male patient presents with persistent heartburn, regurgitation of food, and a sensation of a lump in his throat. These symptoms have been present for the past 6 months. His physician diagnoses him with gastroesophageal reflux disease (GERD). Which of the following is the most important first-line treatment strategy for managing GERD in this patient, and what lifestyle modifications should be recommended? Answer: the first-line treatment for GERD is the use of proton pump inhibitors, PPIs such as omeprazole or lansoprazole. PPIs are effective in reducing gastric acid production, which helps to alleviate the symptoms and prevent esophageal damage. Antacids and H blockers are also used, but are generally less potent than PPIs. In addition to pharmacologic treatment, lifestyle modifications are crucial in managing GERD. These include Weight loss if the patient is overweight, avoiding triggers such as spicy foods, caffeine, alcohol, and chocolate, eating smaller meals to reduce the likelihood of reflux, avoiding eating late at night or lying down immediately after eating, raising the head of the bed to prevent nocturnal reflux. Patients with GERD should also be educated on the risks of esophageal stricture and Barrett's esophagus, conditions that can arise from chronic acid exposure. A patient with a history of chronic alcohol use presents with fatigue, jaundice, and ascites. Physical examination reveals hepatomegaly and spider angiomata. What is the most likely diagnosis and what are the primary treatment goals for managing this condition? Answer: the most likely diagnosis is cirrhosis of the liver, which is commonly caused by chronic alcohol consumption. Cirrhosis leads to progressive liver fibrosis and hepatic dysfunction. The signs and symptoms of cirrhosis can include fatigue, jaundice, ascites, and spider angiomata due to impaired liver function. The primary treatment goals for managing cirrhosis are preventing further liver damage. This involves abstinence from alcohol, controlling risk factors for hepatitis, and managing metabolic disorders like fatty liver disease, treating complications, such as managing ascites with diuretics, spironolactone, furosemide, managing variceal bleeding, e.g. beta blockers or endoscopic treatment, and addressing hepatic encephalopathy with lactulose. Monitoring for hepatocellular carcinoma (HCC) through regular screening with ultrasound and alpha-fetoprotein testing. Liver transplantation in cases of decompensated cirrhosis or when there is progression to liver failure. Mr. Thompson, a 60-year-old male, presents to the clinic with complaints of bloody diarrhea and abdominal pain. His symptoms have been ongoing for several weeks and he has noticed weight loss. On examination, you find erythema nodosum on his lower legs, a sign of extraintestinal manifestation. A colonoscopy confirms ulcerative colitis UC. What is the most appropriate initial treatment approach for Mr. Thompson? Answer: the most appropriate initial treatment for ulcerative colitis UC is the use of aminosalicylates, e.g. mesalamine, which act as anti-inflammatory agents and other first-line therapy for mild to moderate UC. For moderate to severe disease, corticosteroids, e.g. prednisone, are commonly used for short-term flare-ups to control inflammation. However, long-term steroid use is not recommended due to side effects. In addition to pharmacologic therapy, dietary modifications and stress management can help manage symptoms. It's also important to monitor for complications such as toxic megacolon, which can occur in severe cases of UC. If the disease becomes refractory, or if complications arise, immunosuppressive therapy, e.g. azathioprine or biologics like infliximab, may be required. 50-year-old female presents with weight gain, hypertension, bruising, and moon phases. Laboratory results show elevated cortisol levels, and the diagnosis of Cushing's syndrome is suspected. What is the next step in the diagnostic workup, and what is the underlying pathophysiology of Cushing's syndrome? Answer: the next step in the diagnostic workup of Cushing's syndrome is to perform a 24-hour urinary free cortisol test or a low-dose dexamethasone suppression test. The 24-hour urinary free cortisol test is considered the gold standard for diagnosing hypercortisolism. If these tests are positive, further investigation to determine the source of excess cortisol is necessary. This could involve imaging studies such as a CT scan or MRI of the adrenal glands or pituitary, depending on whether the source is adrenal adenoma or carcinoma, or pituitary, Cushing's disease due to pituitary adenoma. The underlying pathophysiology of Cushing's syndrome involves excessive cortisol production, which can result from a variety of causes, including adrenal tumors, pituitary adenomas, Cushing's disease, or atopicase CTH secretion. Excess cortisol leads to protein catabolism, glucose intolerance, and fat redistribution. Moon face, buffalo hump, central obesity. A patient presents with sudden onset dyspnea, pleuritic chest pain, and tachycardia. CT pulmonary angiography confirms a pulmonary embolism. Discuss the initial management steps and indications for thrombolysis. Answer: initial management. Anticoagulation. Start with LMWH or a direct oral anticoagulant DOAC like rivaroxaban. Supportive care. Oxygen therapy and hemodynamic support. Thrombolysis indicated for massive PE with hemodynamic instability, e.g. systolic BP. 9-MAG agents like alteplase are used. Relevant guidelines. ACCP guidelines recommend DOACs over warfarin for most cases of PE, with thrombolysis reserved for high-risk cases. Explain the differences between primary, essential, and secondary hypertension and list 3 common causes of secondary hypertension. Answer: Primary and essential hypertension is the most common form of hypertension and has no identifiable cause. It is typically related to a combination of genetic predisposition, environmental factors, e.g. diet, physical activity, and lifestyle choices, e.g. obesity. Smoking is a diagnosis of exclusion after ruling out secondary causes. A secondary hypertension, on the other hand, is caused by an underlying medical condition. Common causes include renal artery stenosis. Narrowing of the renal arteries, often due to atherosclerosis, leads to reduced renal blood flow, activating the renin-angiotensin-aldosterone system, thus and increasing blood pressure. Hyperaldosteronism, overproduction of aldosterone, often due to an adrenal adenoma. Conn syndrome leads to sodium and water retention, resulting in hypertension. Pheochromocytoma, a tumor of the adrenal medulla that secretes catecholamines, leading to episodic hypertension. Diagnosis of secondary hypertension involves a thorough history, physical exam, and laboratory tests aimed at identifying the underlying cause. What is the gold standard diagnostic test for obstructive sleep apnea, and what are its main features? Answer. The gold standard diagnostic test for obstructive sleep apnea, OSA, is polysomnography, also called an overnight sleep study. This test is typically performed in a sleep center where the patient is monitored overnight. Key features of polysomnography include electroencephalography, EEG, to monitor brain waves and stages of sleep, electroculography, EUG, to assess eye movements and detect REM sleep, electromyography, M, to measure muscle activity, particularly from the chin and legs, to identify any motor activity during sleep, airflow monitoring using nasal and oral thermistors to detect apnea's complete cessation of airflow or hypopnea's partial cessation of airflow, pulse oximetry to measure oxygen saturation levels, helping to identify hypoxemic events during sleep, respiratory effort belts placed around the chest and abdomen to monitor respiratory effort and identify obstructive events, EKG to monitor for arrhythmias that may occur during apneas. Polysomnography allows for the accurate identification of the frequency of apneas and hypopneas, determining the apnea-hypopnea index, AHI, which classifies the severity of OSA, mild, moderate, or severe. Home sleep apnea tests, HSATs, are an alternative for some patients with a high pretest probability of OSA but cannot replace polysomnography for complex cases. A patient with a history of chronic alcohol use presents with a severe headache, confusion, and visual disturbances. On examination, the patient is ataxic, has nystagmus, and a broad-based gait. What is the most likely diagnosis and what is the primary treatment? Answer. The most likely diagnosis is Wernicke's encephalopathy, a neurologic emergency resulting from thiamine, vitamin B deficiency, often due to chronic alcohol use. It presents with the classic triad of ataxia, difficulty coordinating muscle movements leading to an unsteady gait, ocular abnormalities, including nystagmus and ophthalmoplegia, paralysis or weakness of the eye muscles, confusion, cognitive disturbances including memory problems and delirium. The primary treatment is the prompt administration of thiamine. The preferred route is intravenous romaniamine, a dose of 500 mg for the first 2-4-8 hours. This is usually followed by oral thiamine once the patient is stabilized. Thiamine should be administered before glucose is given to avoid precipitating Wernicke's encephalopathy, as glucose administration in a thiamine-deficient patient can worsen the condition. In addition to thiamine, patients should receive nutritional support and the underlying alcohol use should be addressed. Discuss the typical presentation of gastroesophageal reflux disease (GERD) and its first-line management strategies. Answer. GERD typically presents with symptoms of heartburn, regurgitation, and a sour taste in the mouth. It often worsens after meals or when lying down and is exacerbated by foods that relax the lower esophageal sphincter, such as fatty meals, chocolate, and caffeine. Patients may also experience dysphagia, difficulty swallowing, chronic cough, or asthma-like symptoms. The first-line management of GERD includes lifestyle modifications, weight loss in overweight patients, elevating the head of the bed to prevent nighttime reflux, avoiding late meals, caffeine, chocolate, and alcohol, pharmacological therapy, proton pump inhibitors, PPSE, omeprazole, lansoprazole are the most effective agents, reducing gastric acid production. They are typically prescribed for 8 weeks for symptom control. A receptor antagonist, c.g. ranitidine, can be used for less severe symptoms. Antacids and alginate-based medications, e.g. Gaviscon, can be used for symptomatic relief. Surgical options. If symptoms persist despite medical therapy, fundoplication, a procedure to tighten the lower esophageal sphincter, may be considered for refractory cases. Guidelines from the American College of Gastroenterology (ACT) suggest using PPs as first-line therapy for patients with persistent or severe GERD symptoms. A 70-year-old male with a history of hypertension and smoking presents with worsening exertional dyspnea, fatigue, and bilateral lower extremity edema. His BNP is elevated and his echocardiogram shows an EF of 40%. What is the most likely diagnosis and what are the management options? Answer: the most likely diagnosis is diastolic heart failure, also called heart failure with preserved ejection fraction, or HFpEF, as indicated by the patient's symptoms of dyspnea, edema, and EF of 40%, which is preserved or near normal. The elevated BNP also suggests heart failure. Management includes lifestyle modifications, restricting sodium intake and promoting fluid balance, pharmacological therapy, diuretics, e.g. furosemide, for symptom control, especially to reduce fluid overload, SE inhibitors or ARBs to reduce afterload and control blood pressure, beta blockers, e.g. metoprolol, to reduce heart rate and improve cardiac relaxation, aldosterone antagonists, e.g. spironolactone, for fluid management and survival benefit in patients with HFpEF. Comorbidity management. Managing underlying conditions like hypertension, diabetes, and atrial fibrillation is crucial. A 32-year-old woman presents with painful oral ulcers, a butterfly-shaped rash across the face, and joint pain. Laboratory results show positive anti-nuclear antibodies and anti-DNA antibodies. What is the likely diagnosis and what are the first-line treatments? Answer: the likely diagnosis is systemic lupus erythematosus, SLE, an autoimmune disease characterized by a range of symptoms including oral ulcers, malar rash, butterfly-shaped rash, and arthralgia, joint pain. Positive anti-nuclear antibodies and anti-DNA antibodies are highly suggestive of SLE, particularly when coupled with clinical symptoms. First-line treatments include hydroxychloroquine, a cornerstone in managing lupus, especially for skin and joint involvement. Non-steroidal anti-inflammatory drugs, NSAIDs, for managing mild symptoms such as joint pain and fever. Corticosteroids, e.g. prednisone, for controlling acute flares and inflammation. Immunosuppressive agents, e.g. azathioprine, mycophenolate mofetil, for patients with more severe or refractory disease, especially those with renal involvement. Belimumab, a monoclonal antibody that inhibits B-cell activating factor BAFF and is used for SLE in patients with active disease. A 28-year-old male with a history of type 1 diabetes mellitus presents with polydipsia, polyuria, and weight loss. His blood glucose level is significantly elevated. What is the most likely complication he is at risk for, and what are the immediate treatment steps? Answer: the most likely complication for this patient is diabetic ketoacidosis, DKA, a life-threatening emergency in individuals with type 1 diabetes. DKA occurs due to a severe insulin deficiency leading to increased fat metabolism and the production of ketones, which causes metabolic acidosis. Symptoms include polydipsia, polyuria, weight loss, nausea, vomiting, fruity breath due to acetone, and cusmal breathing, deep labored breathing. The patient may also exhibit dehydration, hypotension, and tachycardia. Immediate treatment involves fluid replacement. Start with an isotonic solution like normal saline to address dehydration. The goal is to restore fluid volume, maintain tissue perfusion, and normalize electrolyte imbalances. Hypotension and tachycardia should improve as fluids are given. Insulin therapy. Administer IV insulin to reduce hypoglycemia and halt ketone production. Initially, a continuous insulin infusion is used and blood glucose levels are monitored every hour to adjust the insulin dosage. The goal is to reduce blood glucose at a safe rate of 7 mdl per hour. Electrolyte management. Potassium levels must be closely monitored, as insulin can cause a shift of potassium into cells, potentially resulting in hypokalemia. Potassium replacement may be necessary. Correction of acidosis. Sodium bicarbonate is only given if the pH is 6.9, as excessive bicarbonate can lead to complications like cerebral edema. If there is no improvement, or if the patient develops complications like cerebral edema, septic shock, or arrhythmias, immediate ICU admission is necessary. A 45-year-old woman with a long-standing history of ulcerative colitis presents with severe abdominal pain, fever, and a significant drop in blood pressure. Her condition has worsened in the past 24 hours. Which of the following is the most concerning complication in this scenario? Answer: the most concerning complication in this scenario is toxic megacolon, a life-threatening condition that can arise in patients with severe ulcerative colitis. Toxic megacolon occurs due to an extreme inflammatory response that leads to severe dilation of the colon. It is associated with symptoms of fever, abdominal distension, severe abdominal pain, and hypotension, which can progress to shock. The pathophysiology of toxic megacolon involves a combination of inflammation, dilated bowel, and a decreased ability of the colon to contract, leading to colonic distension. The distension can cause bacterial overgrowth, and the systemic inflammatory response may lead to sepsis, which further worsens the patient's condition. The immediate management involves hospitalization for supportive care, IV antibiotics, and IV corticosteroids to control inflammation. Bowel rest by stopping oral intake and providing nasogastric decompression. Close monitoring for signs of perforation, which would require surgical intervention, colectomy. If the patient fails to improve with medical therapy, a surgical consultation is necessary to evaluate for the need for a colectomy, removal of the colon. Toxic megacolon is a medical emergency and requires prompt treatment to prevent colonic perforation, which can be fatal if untreated. A 45-year-old female presents with weight gain, hypertension, bruising, and moon phases. Laboratory results show elevated cortisol levels, and a diagnosis of Cushing's syndrome is suspected. What is the next step in the diagnostic workup, and what is the underlying pathophysiology of Cushing's syndrome? Answer: the next step in the diagnostic workup for Cushing's syndrome is to perform a 24-hour urinary free cortisol test, a low-dose dexamethasone suppression test, or an ACTH, adrenocorticotropic hormone level test. The 24-hour urinary free cortisol is considered the gold standard for confirming hypercortisolism, and it is often followed by the dexamethasone suppression test, where dexamethasone, a synthetic glucocorticoid, is administered to suppress the pituitary gland's ACTH release. In cases of Cushing's disease, due to a pituitary adenoma, the cortisol levels will not be adequately suppressed. The underlying pathophysiology of Cushing's syndrome involves excess cortisol production. This can occur due to several causes. Cushing's disease, where a pituitary adenoma overproduces ACTH, stimulating the adrenal glands to produce excess cortisol. Adrenal adenomas or carcinomas, which produce cortisol independent of ACTH regulation. Ectopic ACTH secretion, typically from non-pituitary tumors such as small cell lung cancer. Excess cortisol leads to a catabolic state resulting in muscle wasting, glucose intolerance, central obesity, and skin thinning, leading to bruising and striae. A 32-year-old woman presents with fatigue, cold intolerance, weight gain, and constipation. Laboratory results show elevated TSH and load. What is the most likely diagnosis, and what is the first-line treatment? Answer: the most likely diagnosis is hypothyroidism, characterized by a low thyroid hormone level and an elevated TSH level. Hypothyroidism occurs when the thyroid gland is unable to produce enough thyroid hormones, leading to a compensatory increase in TSH from the pituitary to stimulate the thyroid to produce more hormones. Symptoms of hypothyroidism include fatigue, cold intolerance, weight gain, constipation, dry skin, and depression. The first-line treatment for hypothyroidism is the administration of levothyroxine, a synthetic form of. The goal of therapy is to normalize the TSH level and resolve the symptoms of hypothyroidism. Levothyroxine is typically started at a low dose and adjusted based on subsequent TSH and free levels. Once the patient's thyroid function is normalized, she should feel an improvement in energy levels, temperature tolerance, and other symptoms. Treatment should be monitored by measuring TSH and free T levels approximately every 6-8 weeks initially, and then every 1-2 months once stable. It's important to adjust the dose of levothyroxine in pregnant women or those with significant changes in weight, as these factors can alter thyroid hormone requirements. Mr. Arnold, a 50-year-old male, presents to the emergency department with severe epigastric pain that radiates to his back associated with nausea and vomiting. He has a history of chronic alcohol use. His serum lipase and amylase levels are significantly elevated. What is the likely diagnosis, and what are the immediate steps in management? Answer: the most likely diagnosis is acute pancreatitis, which is commonly associated with chronic alcohol use or gallstones. The characteristic symptoms of epigastric pain radiating to the back, accompanied by nausea and vomiting, suggest an acute inflammatory process in the pancreas. The elevated serum lipase and amylase levels confirm the diagnosis, with lipase being more specific and sensitive for pancreatitis. The management of acute pancreatitis includes fluid resuscitation. IV fluids are critical in the initial management to prevent hypovolemia and correct electrolyte imbalances. Normal saline or Ringer's lactate is typically used. Pain control. Analgesics such as opioids are often required to manage severe abdominal pain. NPO status: nothing by mouth. The patient should be kept NPO to allow the pancreas to rest and avoid stimulating further enzyme production. monitoring for complications. Regular monitoring of vital signs, electrolytes, and organ function is essential. Nutritional support. Once the patient stabilizes, oral feeding can be reintroduced slowly. In severe cases, enteral nutrition via a nasogeal tube may be necessary if oral intake is contraindicated. What are the main causes of acute kidney injury, AKI, and how do the staging criteria influence the management and prognosis of the condition? Answer: acute kidney injury, AKI, is typically caused by prerenal, intrinsic renal, or postrenal factors. Prerenal causes are often due to reduced renal perfusion, such as hypovolemia or heart failure. Intrinsic renal causes include conditions like acute tubular necrosis, atent glomerulonephritis, and acute interstitial nephritis, while postrenal causes are primarily related to obstruction of the urinary tract. The KDIGO, kidney disease, improving global outcomes staging criteria for AKI classify the severity based on serum creatinine levels and urine output. Stage 1. Serum creatinine increase of 1.5 to 1.9 times baseline or urine output less than 0.80 for 6-12 hours. Stage 2. Serum creatinine increase of 2 to 2.9 times baseline or urine output less than 0.5 for 12 hours. Stage 3. Serum creatinine increase of 3 times baseline or urine output less than 0.3 AH for 24 hours or anuria for 12 hours. Management depends on the stage, with supportive measures such as fluid resuscitation for prerenal causes, avoidance of nephrotoxic drugs, and treatment of the underlying cause.